when you work in a hospital, you have a different perspective than outpatient because a lot of people get admitted to the hospitals and the diagnoses are provisional and the cases are really acute as they come in. And so you have to try to figure out what's going on, lots of testing, et cetera. And that's going to be one of the other sort of processes we're going to talk about. And there's a kind of tradition in medicine of like trying to figure out what the subgroups are and the differences in presentation. You know, everybody getting treated with antipsychotics who has a psychotic illness, that's putting everything together in a big ball. And then, but we know that behind it, there are many different sub-pathophysiologies, as we call it. And we've been noticing something we think is different in the last 24, 36 months, which is the way in which cases are presenting again is different. They're often more severe, they're less responsive, they all have a history of exposure to different substances as the kids are growing up. And it's one of the changes. So one of the things that Sophia, Dr. Walker, and I, and the others have been noticing is it has a kind of pattern that's reminiscent of something that was written about in the past. So Sophia's going to talk about that, and I'll jump in and out about it.
There you go, Rob. So I think we can go to the next slide. Here's our disclosures. We don't have any. We have some university affiliations that can be no surprise to you. And of course, we're at Silver Hill. I want to, before we go into a little bit of the details that Rocky is talking about, I want to first highlight why this is so important, why it's important to really chase down answers and also from an intellectual perspective, look at the etiologies of illness and also to consider what could be going on in the background and what could be affecting treatment resistance. And the bottom line is that people don't always get better when we use blanket treatments. Our treatments in psychiatry, in most of medicine, but especially in psychiatry, are actually symptomatic treatments. They're not actually hitting the etiology of illness. This is across the board, but most especially in psychiatry, and it really is a limitation. So it's important to make sure we're optimizing how we diagnose people, how we complete our workups, how open-minded we are, so that we can improve outcomes. Next one. This is a little bit of what Rocky was going into. Some of the changing trends we are seeing at the hospital in the last 10 years, but definitely, especially since the pandemic in 2020. So in the last few years, earlier first episodes of frank psychosis. So this is not the prodrome that Dr. Laitman was referring to, but frank florid psychosis. We're seeing it earlier. On top of that, the presentations are much more complex and florid, much more bizarre, and a much larger constellation of symptoms. On top of that, a much greater resistance to treatment. We'll see a table of a couple cases here where even clozapine was an issue. Some people had to stop clozapine, then get restarted with additional adjunctive treatments, and we'll go into that a little bit. Additionally, these cases were actually marked by fewer negative symptoms. So some negative symptoms were there, some cognitive issues were there, but overall, intellect was intact, and most especially abstract thought in these cases intact, which is really something that's different from the classical schizophrenia presentation. Additionally, a lot of these patients happen to be brilliant artists, painters, and writers, people who have a wide range of skills that really is a highlight of that abstract thinking. That being said, still low levels of functioning overall. So Dr. Laitman was mentioning this differential in the neuropsychological testing of some areas of really demonstrating very high intellect, but then very low functioning, low processing speed in other areas. This is a hallmark of some of these presentations. We're marked by a lot of grandiosity, hyperreligiosity, which On premature closure, we would say, okay, bipolar. Well, not necessarily always and not exactly. On top of that, lots of substance use. And something I want to highlight is that not only cannabis, but also early use of psychostimulants, is whether prescribed or not. So especially early in life in the pre-puberty or even in teenage years. Nothing that we can be surprised by, because in the last 30 years, there's been a huge increase in stimulant prescribing. I'm a child psychiatrist, so I'm totally one of the people in the field who is actually a perpetrator of this. So sometimes we need to reflect on our own behaviors and our own our use of treatments and medicine. That's critical. Lastly, a lot of people reporting that benzodiazepines and alcohol actually improved symptoms, and in a very clear and distinct way, not in the, oh, my anxiety is relieved, but actual distinct symptoms improved. And, you know, I think that's a big key here, because oftentimes we need to listen to our patients. We always need to listen to them, but we shouldn't dismiss their perspective, even when, and also probably especially when there's an experience they're having that we cannot relate to, i.e. the break from reality psychosis. So let's go on. Here's a couple examples. And we'll kind of walk through each of these cases as we go through the lecture. So this female was 25 years old. The first presentation was psychosis, was somewhere around 19, 20, 21 or so. Upper middle class girl. These are the highlights. Really intelligent, charming, like really socially able to interact well. So not what really looks like the beginning of those negative and cognitive symptoms in the beginning of the illness. On top of that, she had a lot of emotional instability and psychotic symptoms. As I said, in her late teenage years even. She was also very strong-willed, very quick verbally, and very accomplished. She would have episodes of what she would call tripping. And because she had a history of substance use, it was always chalked up to, okay, a substance-induced psychosis. These symptoms, oh, that was part of the substance use, etc. She also had, initially, she was saying that she didn't ever have any visual hallucinations or any auditory hallucinations. The more she got to know Dr. Marotta, because this is his case, the more she got to know him, she actually would admit that she had very well developed and like very well formed visual hallucinations and quite exotic experiences. On top of that, she would have auditory hallucinations that were quite well defined. And she often was found, I believe, on the inpatient unit and in the lodge, like having full conversations with someone who person wasn't there. And when asked what she was doing, she would say, oh, I was just thinking to myself or something like that. She wouldn't admit that there was this, you know, other conversation that she was having. That's part of that anosognosia even. She went through, this can be no surprise to all of you, multiple admissions, multiple diagnoses. She had done a lot of ECT. On top of that, initially with the ECT, there were some positive effects, but it kind of tapered off, wasn't clear. And yes, she used marijuana and hallucinogens, as I discussed before. So next slide. Here's another case. And it's okay, we'll keep track of the cases. I'll remind you where we are with each one. The second case is a male, 29 years old, but the psychosis and the bizarre experiences dated back to being a teenager even. This was a kiddo who's multilingual. He spoke many languages fluently and difficult languages like Russian and Arabic fluently. Had a very high IQ, like in the 140s or like low 150s or something like that. And he also had multiple previous diagnoses, multiple previous psychiatric hospitalizations with no success. Back even in pre-puberty, he said he always would feel strange, would always feel off. And he would feel that when these experiences came on, if he took a benzodiazepine or drank alcohol, the symptoms would improve. And as a result, because it was alcohol and because it was a controlled substance, the benzodiazepines, no one would prescribe them for him. So he was suffering a great deal and without any answers. I think we kind of went into this. Something I want to highlight here actually is that his visual hallucinations were really marked and bizarre. I mean, speaking with him on that really should have, up until the point he saw Dr. Marotta, really should have triggered someone looking into biological underpinnings of his illness, because he would see things like plants moving and like plants breathing and all kinds of experiences like that. He could see like sheets of music or hear music playing through the walls, and very, very bizarre and very illustrative visual and auditory hallucinations. Next slide. Here's the question is, why are things looking different? What's going on? Is this just the evolution of schizophrenia? Is this just a different way psychosis might look in the subset of patients and that's it? Is it bipolar disorder and people are reporting something different and bizarre in the context of a mania or a psychotic episode? Is it personality disorders? Is it psychosis and personality, especially cluster B personalities? Because these two patients and a few of the other ones that we'll talk about actually did have personality disorder as a diagnosis as well. Is there something going on physiologically underneath? Or could this be a manifestation of partial complex seizures? So next slide. This is a little joke on my part, but as Rocky just said, we have the time and the opportunity, we have the resources at Silver Hill to really chase down a lot of medical workup. So we're just gonna say that Rocky did all of that, okay? Just so we don't go through the whole thing and we're not here all day. But let's look at seizure disorders. Something to remember is that discussion of seizure disorders as it relates to psychosis, especially in the temporal lobes, already exists in the literature. It's there, much more rare, not necessarily common, but Leishman, this is in his third edition in '98, but even years before that, described the interplay between neurology and psychiatry and psychosis and seizures. So this is not something that is out of the blue that, you know, Rocky and I are just making up. This is something that is in the literature and had been seen before. Next slide. There's also a lot of medical conditions that need to be distinguished from seizure disorders. And what's important to remember is the hallmarks of some of the symptoms, all the way from panic disorder to stress reactions to personality disorders to even malingering or migraines, they all kind of can fit those two cases a little bit, right? You could kind of pin one of these labels on those. And psychosis is on the differential with seizures as well. Next slide. Here's some things that they have in common: seizure disorders and psychoses. They're both modulated by dopamine. This is where all the clozapine stuff will come in too. And on top of that, they present at similar ages and at a similar developmental trajectory. And Dr. Laitman went into the whole background of how schizophrenia is really a neurodevelopmental disorder. And that's very important to remember. On top of that, the genetic frequencies are about the same. Seizures run in families the way psychosis does. That's also critical to remember. And on top of that, these are really highly complex disorders that often go misdiagnosed or missed, and they require a highly skilled treatment team. Next slide. This is something I also want to bring up, which is described in the literature in quite a lot of detail, is what was called the epileptic personality. And I think if you read through some of these symptoms, it's actually consistent with some of the changing trends I was describing at the beginning of our talk. So a lot of these like religious and philosophical preoccupations, a lot of sexual preoccupation, but hyposexuality, a lot of paranoia, etc. Next slide. So Rocky found a questionnaire that had been used very widely looking at partial complex seizures. And he went through these questions as part of his medical workup of some of these patients. And if they came out positive, he would then reach out to a neurologist and, expand the workup and really make the case that something else is going on here because the treatments are not working. What I really want to highlight is that a lot of the questions, the main focus of each of the questions is bolded. And the reason I'm doing that is so that you kind of can pull out from each question the basic idea. But the entire question is always important because you don't want to be suggestive in your questioning patients, especially because a lot of these questions are subjective. The question of nightmares, sleepwalking, some might actually be able to tell you, like a family member, right? But the experiences of tingling and numbness, or the sensation of palpitations, feeling that you can sense the future, or having deja vu experiences or jamais vu experiences. Jamais vu is like you've never experienced something before and you feel like you're completely disoriented in a setting and everything is unfamiliar around you. Experiences like that, they're all completely subjective, right? You could always chalk up symptoms like this to, oh, someone is just psychotic. They're having a break from reality. They're dissociating, right? This is part of the psychosis. So next slide. Let's go back to that first case. So I'll direct your attention to the first case at the very top. This was the girl who was 25. At 21 years old was the first presentation of psychosis. Now I'm realizing this is all very small, but on that partial complex seizure checklist, right? She had distortion in colors and shapes. She had nightmares. She felt she could foretell the future. She was saying she was having these tripping, dissociative experiences. Her score was very high on that questionnaire. And that's what triggered a further workup with neuroimaging that Dr. Cavalli will go into. Thank you. Oh, awesome.
Down, slide to.
Oh, amazing. Oh, wow, this is so high tech. Leave it to our radiologist to help us out on. Dr. Cavalli will go into the details of neuroimaging, but on the neuroimaging, what we found is there was decreased perfusion in the right anterior temporal lobes in this patient. That's really important to recognize because this is where partial complex seizures sit, in the temporal lobes. And so Rocky was able to make this connection, and ultimately, in addition to clozapine and oxytocin, which we've already discussed and you're all familiar with, he also added an anti-epileptic here with advice from the neurologist, which actually led to this patient getting better and also allowed the further titration of the clozapine. Something that also shouldn't be a surprise to anyone is that at higher doses, clozapine can cause seizures actually. And so you need to use some seizure prophylaxis. But this dose here, I didn't go into the details in this table, but it went much higher than you would expect. Now, that second case, our male who started having frank psychotic episodes since 16 years old, but prior to that had always had these experiences of feeling off, etc. This was a kiddo who, as I mentioned before, he had been on stimulants growing up for ADHD and had been using a lot of marijuana in college. On top of that, on that partial complex seizure checklist, he had a lot of the symptoms that we were describing, right? Especially marked by, on top of everything else, a lot of head injuries and a lot of that color and shape distortion, paresthesias, lots of staring, lots of episodes of loss of consciousness, and also decreased perfusion in the right temporal lobe on neuroimaging. And one thing I want to bring up is sometimes EEGs are not mentioned here, and the reason is we don't have space, but the part of it is that you don't always find on EEG a seizure. A person may not have a seizure, or sometimes a seizure may not, if a person does have a seizure physically, you may not catch it on an EEG. So that's a real challenge, because then we chalk things up to, you know, I don't know, patients making things up or having a break from reality, et cetera. And we don't chase these things down. Ultimately, this patient really struggled with Clozaril. And so he ended up on two anti-epileptics that are also mood stabilizers, the valproate and the lamotrigine, as well as clonazepam and very high doses of Seroquel, and is doing great. Now, why are these two cases in the context of a greater, larger table? Well, this is what we presented at SIRS this year in Florence, like last week. And here we're looking at 10 cases. There's actually a few more, and we didn't add them because A, it was getting a bit exhaustive, and B, because we didn't have every last bit of data on them in the chart, and so we didn't go into it. But here's those same trends we were discussing, right? So actually a preponderance of females, earlier presentations of frank psychosis, right? But not that surprising. Like with classical schizophrenia, you would also see this, right? Fewer negative symptoms, the intact intellect, but a lot of overt violence, especially in females, a lot of bizarre hallucinations, grandiosity, etc. Most of these kids were on stimulants at some point. I say kids, but I mean, you know, at stimulants at some point. On top of that, all of them had used marijuana at some point, and many of them had had that benefit from benzodiazepines that I described from the male. They all, from the second case. On top of that, with this complex seizure questionnaire, they all met criteria. They all had pretty significant symptoms that were consistent. Everybody's symptoms were unique, but once you kind of dug into it and went through it with them, you would get this information out. And Rocky's very good at getting information out of his patients. All had abnormalities in the temporal lobes, also other lobes as well. Anterior, parietal, and occipital sometimes, but especially in the temporal lobes. And they ultimately all required anti-epileptic medication and mood stabilizers to ensure that they did well clinically. Can you do the next slide? I don't know why I'm not getting it to work. Oh, the down button, okay. Okay. You know, a lot of people have asked me, so are you saying that the seizures are causing the psychosis? No. What we're saying is that, first of all, it seems like there's some connection. It seems like there's an interplay. There's some association, and it's been found in the literature. So, you know, it's worth exploring further. It's not something that we're just making up. On top of that, something to remember here is that remember that in all these cases, we did identify underlying brain differences and abnormalities you wouldn't expect to see if it wasn't for abnormalities in the temporal lobes. So even if we're not seeing a fully manifested seizure disorder, right? Even if it's not technically diagnosable, there are some abnormalities there. We don't have the tools to parse all of that out. The science isn't there yet. What's important to remember is that it's the balance between the two that kind of keeps the illness going and prevents optimal recovery. And that's why you need the balance of the antipsychotic, most especially clozapine in these cases, and the anti-epileptic medication. And actually, the literature also demonstrates that when you use a lot of antipsychotic, you can actually make seizures worse and vice versa. If you use a lot of seizure medication without the balance of the antipsychotic, you can make the psychosis worse. So, as I said before, cases like this have been seen before. They're very well described, and they're often called schizophrenia-like psychoses of epilepsy. That's going back to Leishman and like the neuropsych textbooks. So the trend we're seeing, the issue here is that it's not that it's a brand new etiology. It's not a brand new phenomenon that we're identifying. We're identifying a change in the frequency of this coming up at the hospital, especially in cases of treatment resistance. Okay, there we go. So why are we seeing more of this now? And we don't know. The truth is we don't know. But something we can't deny is that there's a lot of high potency synthetic drugs that also are genetically modified on top of that to be more potent. So we're talking about marijuana, we're talking about cannabis, but on top of that, we're talking about the fact that in the last 30 years, we've been prescribing stimulants to people who are developing. And that might not be the wrong thing to do. I'm not saying that at all, but it could be the case that this is resulting in unmasking of underlying brain vulnerabilities that we would otherwise have never seen before. On top of that, we're living in a society that has induced a lot of stress artificially. And on top of that, we've lived through a pandemic that has infected literally everybody, right? Not only are there psychological stressors related to the COVID-19 pandemic, but on top of that, COVID-19 is highly immunogenic. And Dr. Laitman just spoke to us about the complement system and the immune modulation that gets involved with schizophrenia, gets involved with psychosis, and the evidence that clozapine can actually reduce that. Yeah, we went through all this. Next slide. So here's what Rocky and I want to talk about and think about. What does this mean ultimately? What are we really getting at here? And also, what do we need to look for? How do we need to change our behavior when we're working patients up? How open-minded do we need to be about this? And what are the signs that we need to look for to make sure we're working things up correctly? And also, what additional resources do we need so that we can treat patients optimally and also prevent these illnesses, right? So anyway, that's what we wanted to go into. I think we might have caught up because I think I tried to go pretty quickly.
It's a couple of points. One is that
I think you're, are you on? Okay, you're good.
okay, maybe I'm not speaking, is that an underlying epileptic condition does not mean it has to be an overt seizure. It means that there's an area of tissue that's dysfunctioning, right? The other thing is that you won't see it on an EEG unless it's near the surface and you catch it at the right time. And that these things have certain things in common. So that was one thing. The other thing is tying into the whole case presentation. The second case that she outlined for the young man with the multiple languages. So my nickname for him is Odysseus. Odysseus had a terrible time in college. He was always in and out of strange things that were going on. When he would get admitted to the hospital, they would admit him for DTs. Right? They would say he was just an alcoholic, a young terribly alcoholic. Odysseus finished graduate school a few weeks ago and is now working in a dual diagnosis program as a therapist. So he went from being not working, talk about, and that happened faster than we would usually expect, say, from a causal treatment. We had a tough time with him with the clozapine. We had, white count going, all kinds of stuff. He ended up admitted to the hospital. We thought myocarditis, but his father also got very sick. They both got COVID, and it just made a mess of the clozapine treatment. But we came up with a mix that worked for him. And so he's living with a woman, he has a job, he finished graduate school, he's sort of back on track 5 or 6 years later than you would expect somebody with that degree of early education because he was learning those languages early on. The second thing, which is to me, the first case, who it also showed something, which is that my experience with many of our patients is they don't tell us what they're actually experiencing. That many, many more of them are having overt hallucinations and other bizarre experiences. And in fact, the way I often get them to confess to me is I tell them that I know a lot of people have this really weird thing that happens, that they have a voice that tells them not to let anybody know that they have a voice talking to them. And they go, oh, you know about the voice or something like that. Oh, yeah. And I don't say that I don't necessarily have it. I let them know that, oh, this kind of stuff happens all the time, you know. And you can get them to talk more once they know. They may not tell you right away, but it's a way of letting them know that they're not alone in that terrible situation. Um, but that young woman who was, she was a great painter. She really paints beautifully. And on clozapine, her paintings became less dark, less bizarre, less almost possessed, which was interesting. But then she went away to a program which was much more liberal and progressive. I don't know what to call it, you know, much more advanced in California, that thought it was okay to let people with psychotic illnesses smoke a little bit of marijuana in a controlled way. And of course, the whole bloody thing comes apart, you know, because we press and press and press sobriety, you know, sobriety, family involvement, medication compliance, keeping in touch with everybody, you know, listening to mommy and daddy. And she went to a program that was, you know, more about freedom. And I don't like to think of myself as an agent of state oppression, but sometimes I guess I am. And that's heartbreaking because we've had that happen a number of times. And when I say we've lost patients to suicide when other programs in other parts of the country thought that clozapine was not necessary because they weren't showing any psychotic illness in their program for months. And they said, well, why are you putting these people through this terrible thing? And so, and that's heartbreak hotel. That's just as bad as you can get.
Actually, I didn't say a lot of these people now are doing remarkably well. Like,
Yeah, a lot of I think that as a group,
Mhm.
if they stay on the medicines, this is a group, like,
Mhm.
there's another woman in there who, another painter.
oh yeah.
Yeah, another painter who just
Mhm.
paints, you know, beautifully, and people collect her, and
Yeah, it's this one.
so there's, in that grouping,
Mhm.
it's really interesting. Oh,
Mhm.
and there's 3 painters in that? There's 3
No,
who paint?
no, there's like 4 or 5.
Well, but another one is very, very good.
Mhm.
And again, had a terrible
Mhm.
4 or 5 years. Yet on the mix of medications,
Yeah.
is painting more and is happy.
Mhm.
You know,
Mhm.
Odysseus,
Mhm.
I mean, is actually happy.
Mhm.
Uh,
Odysseus is also a writer.
yes, he writes very, very
So a
well.
lot of them are also writers. This outlier actually has a known history of epilepsy. And actually, interestingly enough, is, you know, the symptoms resolved quite quickly. And she's now like working in a real estate firm in New York City in a pretty stressful job and doing quite well. So, this is, I think these are indications that something different is going on
Yeah,
in this subgroup. Um, even though the medications are the same, you know, you do some slightly different things with them.
so you can either put everybody on the whole thing, or
Mhm.
but we were trying to cut out the subgroups and see if there's any different ways we treat the subgroups to
Mhm.
be more
Mhm.
effective or more efficient. But it seemed like we were seeing a lot of it.
Mhm.
That's why we're bringing it up.
Mhm.
I think it's the marijuana and the stimulants. And again, possibly in some of these people who are young,
Mhm.
the COVID, because
Mhm.
to go back, you know, to what Rob has said, it's the immune system is dysregulated in some way. There's, you know, and cannabis does that, COVID does that, right? And then where our mix of medicines
Mhm.
is modulating that.
Mhm.
About the phones.
The telephone.
Yours? You did? Oh,
Yes, yes,
these
yes.
things?
Sorry.
Yeah.
All right, maybe I didn't say it, but yeah, you're right. I didn't say it, but when I went in, so in this component of the social pressures, societal pressures, a big, and actually there's quite a bit of literature on this, that with social media, there's a lot of fragmentation of social interaction. So people are developing differently, and since that's the case, it leaves a lot of people who have underlying brain abnormalities who, as I said before, otherwise wouldn't present, kind of have that additional stress. That's an additional barrier to developing.
and are you seeing a lot more borderline personality disorder? And they make it tough, but you guys had like the premier DBT program
Well, we
Uh,
see,
and still have a good one.
we see a lot of borderline personality disorder because we're a famous hospital for treating borderline personality. And we see a lot of patients who've gone through severe abuse because we have a program that
It
specializes in that.
co-occurs. That's the whole thing. People forget it co-occurs with psychotic
so-
disorders.
But again, the question is, what is it really? For example, in some of these cases, the girls have all had some kind of traumatic sexual experiences. But then again, if you're prone to a disorder of consciousness and perception, who am I to comment on what's really going on, right? And if you put what are the symptoms, say, of bipolar illness or mood disorder next to the symptoms of, borderline personality, there's an enormous overlap. So if there's a pathophysiology of the brain, maybe it overlaps because it's temporal, it's emotional, it's the limbic system. So what are you going to say? But there's a literature that says that antipsychotics help with those states, and lots of patients in those programs are on antipsychotics and mood stabilizers, right? And there are a few papers saying that clozapine is actually a decent treatment for, borderline personality, which is not surprising given what our overall hypotheses are. I'm an agnostic when it comes to diagnostic categories. I worry or think more about what is the constellation of symptoms in any given person and what might we do to impact that. So that's how I try to work my way through it, which is why when we see patients, to talk about another thing, our method is we talk about it. A lot of us in the group will see the same patient and we'll just chat about it. So it's kind of everybody has a case conference sort of ongoing in a group of social workers, RCs, psychiatrists, psychologists that are just back and forth for a while. Not necessarily in the same room, but the world has changed in the last years, but they're feeding information back and forth and rethinking it and coming up with ideas.
The other thing I'd say, Rocky, too, is that when there's a difficult patient and symptoms are not getting better, we have a tendency to say, oh, there's a personality disorder there. And I think the difference in some of these cases is that even though personality disorders are co-occurring, there's also an element of that the countertransference you experience with someone who's very cluster B personality disorder to like borderline personality or narcissistic personality disorder, it's not there with a lot of these patients. They just simply are not getting better and they're difficult. Well, of course they're difficult. It's complicated, as you can see. So I think sometimes what we might be chalking up to personality is really coming from our own frustration. And so I think that's something that's important to remember and parse out correctly, because it could be the case that really there is a co-occurring personality disorder. My argument would be, what exactly are the symptoms that are not changing and not getting better once you've addressed the medical workup and addressed the neurobiological diagnosis, whether it's schizophrenia or otherwise, right? And if they're still prone to essentially identity diffusion, which is what borderline personality disorder is, then okay, there's something to work on there, right? And it doesn't mean that what's done at Silver Hill, primarily the modality of DBT, isn't really useful for everyone. DBT is really a collection of life skills ultimately, right? So, and I wouldn't argue with the issue of co-occurrence so much as what exactly are we saying are the symptoms that are co-occurring, and does that really meet a full criteria for personality disorder? And should we be chalking up symptoms like mood instability, et cetera, to that? Or is there, an underlying biological cause?
So from a treatment point of view, I just want to make sure I'm understanding what you're saying, that, I mean, because I know that many of these patients are prophylactically on anti-seizure meds, right? So are you saying that if somebody's not getting better, the increased use of an anti-seizure, if in fact it looks like seizures are part of the picture, that will potentiate the other medications and help facilitate treatment? Or is it that understanding it from a different perspective allows you then to be not as frustrated, and therefore the work becomes not less complicated, but in some ways is facilitated because you're not struggling with your own frustration in the same kind of way?
The latter is true. Families like answers, patients like answers, and doctors like to solve problems, right? So that's obvious. That's definitely there. What I see different in the treatment of this subset of patients is that something to remember is second generation atypical antipsychotics they also function as mood stabilizers. But here, what the additional adjunctive treatment is specifically an anti-epileptic used as such, right? And so sometimes we do use, not sometimes, very frequently, we use anti-epileptic medications like the lamotrigine or the valproate described for mood stabilization, and they are approved for that purpose. And we also use them for seizure prophylaxis at very high clozapine levels. But beyond that, in these cases, we're actually treating to the underlying the underlying brain abnormality that's being identified. And that's really, it's very even if you're using the same medication, it's critical to know what you're using it for, because if something needs to change or if there's an adverse effect, you have to understand how you're going to function differently should there be an issue, right? And also the third element is that there has to be, in cases like this, the balance between the antipsychotic dose versus the anti-epileptic dose. Yes.
So 2 questions. Well, actually 3. How do you define marijuana use? What does that mean? What are you also linking the idea of an addictive personality to what some of these substances are doing, so the alcohol and the marijuana? And thirdly, are you making some link with the increased and very accepted prescriptions of stimulants in childhood and young adolescents, like the antidepressants, like the Ritalins and that sort of thing? Are we kind of shoot ourselves in the feet by doing that when they're very young and saying, oh, there's something different about this kid, we not need to control them in the classroom, and versus what we're seeing now?
Yeah, so the first one, as far as marijuana use, any and all marijuana use is marijuana use. And the issue there is we don't know, it's not well regulated. And so we don't actually know what people are using. When I speak with people about marijuana use, I get very down to the nitty gritty of like who they're getting the marijuana from and how consistently are they getting it from the same person, or from the same dispensary, et cetera, or if they're getting it from friends, where are those friends getting it from? Because we really don't know what's being used. And we also, from person to person, we also don't know what other substances are mixed in there. And the combination of all of that really leads to a confluence of factors that can unmask an underlying psychosis. So that's the first bit of it. Of course, if there's much more CBD as opposed to THC in the makeup of a particular batch, I suppose, of marijuana, of course, it's going to be less likely to be psychoactive, but it's very difficult to make those distinctions in any kind of practical manner. And so the moment that I see someone has psychosis ongoing, I speak with them very directly, but also their family very directly about this person, and also no one else in the family is to use marijuana going forward, because we don't know who's inherited what genetics, right? So long story short, any use is use, unfortunately. The second question, remind me, it was as to the addictive personality. No, I actually think what's going on here is that it's really entered the norm to use marijuana. Frankly, as I told you, I'm a child psychiatrist. Most teenagers and early and later adolescents, people in their early 20s, they use substances, they experiment with substances. And I don't think you can call that an addictive personality. Also, something to consider is that substances are very potent. They actually do what we say they do, i.e., if you're very stressed out and anxious, yeah, you're going to benefit from marijuana. Yeah, you're going to benefit from heroin, and you're going to benefit from benzodiazepines. We only have a problem with it because there's issues and there's consequences that come with that. Otherwise, why would we make the argument? We would just use those substances as what we prescribe. We can't do that because we would be harming people then. And so that's really the interplay here. And I think that's important to remember, is it's really not worth denying the benefits of these very potent substances, because if we do, we're really undermining ourselves. We're not acknowledging that there's a reason these substances are used and people go to them. We just need to identify other ways that are not harmful for them to get what they need.
And then the link in with alcohol use, which is also systemically affects anybody. I mean, how much does alcohol play into that versus, a couple of drinks is okay. Am I, drinking?
So I think you have to be very careful with patients who I see who have an underlying seizure disorder. I'm actually very adamant that they do not use alcohol, as are their neurologists. And a big reason for that is alcohol is actually a CNS depressant, and while you're intoxicated, increases the seizure threshold, so it makes it harder to have a seizure. But as you're coming off the alcohol, so as it's leaving your system, you're actually dramatically escalating the likelihood of a seizure happening. And I've had actually this patient number 9, they developed psychosis after they probably had a seizure because they were on high doses of Wellbutrin. That particular day, they had a bunch of alcohol, like 5 or 6 drinks. And as a result, like 72 hours later, apparently became very paranoid. So I am very adamant about the use of alcohol in situations like this. And I think we have to remember, as with any substance and anyone's genetic makeup, with any illness in medicine, so psychiatry is not the exclusion here, that we all have to make lifestyle modifications to address our underlying genetic differences. People who have a family history of very high cholesterol really need to be careful with what they eat, and they need to exercise. We're not talking about anything very different here. It just kind of sucks if you can't have a drink here or there, smoke some marijuana with your buddies. But I'll take that over, worsening morbidity and mortality. And the last, I think you had a last question too, right?
And the
Ellen?
other thing was, are we over prescribing the stuff to the kids?
Yeah, yeah. So this worries me a little bit because the more Rocky and I have spoken about this, the more worried I am. I'm not sure about antidepressants and anxiolytics, but I am a bit worried about the stimulants. And there is definite benefit and improved function with stimulant medication and ADHD. I am definitely going 100% against the grain in saying that I have a concern here because children really do benefit. I'm not making the argument that you should never use a psychostimulant. I'm making the argument that stimulants are highly pro-dopaminergic, and what we might be doing is ultimately lowering the threshold for an unmasking of illness later in life, and we don't know who that's going to hit and how. Rob?
I think psychiatrists have to look and actually do a good family history. So if you got a really high polygenetic risk score, you don't use stimulants. If there's no polygenetic risk, yeah, it works. I mean, and selectively you see increased dopamine in the prefrontal cortex. It downregulates in the limbic system. They do have better attention. But if someone has a family history like my son, that was nuts to give him a stimulant. Or if you have developmental disorder, for instance, autism, there's especially males with autism, there's 20% risk of developing psychosis. So if you have that predispositions.
The other thing I want to bring up is very similarly to Dr. Laitman, I actually also require that the patients I see in my private practice, especially young children and teenagers, I do require that they do something that they feel is productive and positive and brings meaning, because that's something I think is missing. But on top of that, I really push for exercise, especially in competitive sports like running or swimming and that kind of thing. And all of that, I argue, can support treatment of ADHD. We're a little bit off tangent there, but in terms of the risk factor that Rocky and I think might be ongoing and highlighted.
Yeah, there's actually a SIRS presentation in high-risk individuals starting at age 10, and they're following them longitudinally, and they're starting to see kids that participate in competitive sports, especially, but all sports, but especially competitive sports, somewhat of a protective factor.
Yeah, I definitely agree with that. Irene, I think you had something.
Yeah, Sophia, I really appreciate your approach, and honesty with what you're speaking. So I want to ask you, because you're, identifying seizures, like you said, we have the EEG and you can't see them unless, so what diagnostics, because I mean, we as always use clinicians, we use our clinical skills, right?
Mhm.
But we do have to have diagnostic documentation of what we're doing. So on long trend, what do you use to follow up to see that seizures are lessening, that kind of thing?
Yeah, absolutely. I think a couple things. The first thing I want to bring up is what Rocky started off with was looking for a clinical assessment of partial complex seizures, that checklist, right?
Right.
So actually, this is not something that's drastically out of the norm. In medicine, we know that 80% of diagnosis comes from the history. To kind of confirm his suspicions, all Rocky did was find an approved study checklist and question the patients in more detail and kind of put together a framework, put together a hypothesis. So that's not something that can't be done in any setting. It can be
But I'm
done in
saying
any.
going forward.
So now beyond that, I think that's, if you have a suspicion of underlying epilepsy, you really need to get a neurologist involved and someone who can be open-minded about this. And that's really challenging. And that's actually, I'll tell you honestly, where it's hard to get done. We have a couple people through Silver Hill. We know, and Dr. Cavalier has connected a couple of Rocky's patients and one of my patients to a system of care that really Cornell, which is at the forefront of epilepsy And so they really are very open-minded about looking at these cases and helping us come up with a cocktail that makes sense. And you do want them to be monitored by a neurologist if possible. And then once you start to see what the pattern is in the particular patient and what specific symptoms they experience, you can generally monitor it, at your interval meetings with them. So for a couple of my patients, I will check in with them about specific symptoms they have and how frequently they're coming up and how disturbing they are to their function.
So the reason this came up, and that's kind of timely, my little cousin, he's 2 years old and was just diagnosed with seizures.
Yeah.
And the diagnostics in the DSM-5 is having a seizure lasting longer than 5 minutes 2 times.
Uh-huh.
Okay, so he has this diagnosis now, and now he's on rectal Valium.
He's on
Right.
what?
Rectal Valium,
Uh-huh.
because that's a treatment for children
Yeah.
with seizures. Okay, so now what happens?
So now you monitor that very carefully.
How?
You monitor it clinically. So he needs to follow up with his neurologist.
Yeah,
And you need to pay he doesn't necessarily need to see a psychiatrist, but you need some education on what are some of the things to look for, because common in the temporal lobe epilepsy picture is mood disorders. I'm not saying he has a temporal lobe epilepsy, by the way, but
yeah.
this is the
yeah.
topic we're on.
Yeah,
Mood disorders, and something like 10 to 15 years out, a possible first episode of psychosis. And so so that means what I would say is he has a definite vulnerability,
Mm.
right? The other thing you want to do is look at what the background is genetically. Are there other possible vulnerabilities he may have? You want to start educating, he's a little young now, but you might want to start educating the parents and the siblings on being really aggressive about education on substance use, because he's going to be disproportionately affected by that. And on top of that, you want to be really careful monitoring his development, and you need to, and by the way, pediatricians are quite good at that, especially in really young kiddos. There's great outlines for that. I think one thing that's important to remember in pediatrics as well is that a lot of times, there's a lot of kids who have need for early intervention services. And so the kids who are kind of on the borderline, they're kind of okay, they're kind of meeting guidelines, they don't get that rehab. You actually want to make sure that if there's any sign that he's falling a little bit behind, you're on top of it, right? And you, even if it's not necessarily recommended, you get him the PT and the OT and the speech therapies, the early intervention services. So it's something you've got to watch and pay attention to. And frankly, it's families that do that. That's the truth.
Yeah, I was
With the
thinking
support of a
more along
doctor.
the lines of, now that he's on the Valium, right? You're not, supposedly not going to see the seizure activity, right?
You shouldn't, but if you do, I would say immediately alert the neurologist, because then you're not controlling.
Yeah, but let's say there's not, he's on the Valium. I mean, 2-year-olds temper tantrums, so mood disorder isn't really something that you're gonna identify. I mean, I'm just thinking ahead of, because we start these meds so young. It's like, at what point in time do we monitor, say, you know what, maybe we shouldn't take these for a while and see what happens?
Yeah, so that's why I think consistent monitoring with the neurologist is important. I think it's important not to go to your doctor when things are bad only. Actually go when things are going okay, so that your team knows what does it look like when things are going well, right? And how do you, if things are going well, then you can work on something like a risk factor, for sure. Any other, I think we're, oh, yeah.
Population up there?
Yeah.
Is it more susceptible now for females to have the temporal lobe?
There's
epilep-
something, this is something Rocky and I are talking about, and maybe I like ran through it quickly and at the beginning of the trend changing, but that actually is one of the change in the trends is there's more females for some reason. We don't, and also females who are actually overtly violent, in fact, towards family members and towards sexual partners, actually. So
It could be a sampling error, it's just the way it turned out. Or it could be that, young women now are using a lot more drugs and are exposed to more violence. And also couple of the young women were really into sports. And you may remember some of them, right? They were really very physical and, they played, we've had several rugby playing women. Yeah. And I wouldn't be surprised if they may have tried some hormone stuff too, because we've had some of the guys who've used hormones. So all these things come into play, you know. I mean, you don't have to have an overt motor seizure to have something wrong. Is the point that I would take. And we have to be aware that we don't know everything. We just don't know. We're just seeing shadows of something going on. And maybe I'm a little hysterical in my old age. Or I don't know, you know.
Any other questions or thoughts?
So one quick question, maybe it's an imaging question, but so I see several of the people have decreased perfusion on their SPECT imaging. So I wonder, is that something that A, is seen in the general population? Is it fixed or reactive? Does it change? And do you notice any association? I know it's not many patients, but is there association with sidedness and handedness of the person in terms of their symptoms?
But the Kavali is going to speak about that in a little bit. Yeah.
Wow. That was a question. Um, Let me start from the beginning. SPECT and using SPECT has been discussed and is valuable. I'm going to talk a little bit more about PET and how there's going to be a little bit of a transition now. What you're saying is, what you're asking is sidedness and the activity, and all of that comes into play. And the answer to that question is yes, and we don't know. Because functional MRI will help us see a little bit better. And the more we do functional MRI, the more we realize that although we like to think about, we know where activity occurs in the brain for certain functions, everyone's different. And until you actually do the functional MRI, do you really, for an individual, then and only then do you really know where the activity is occurring and how much, right, left, what part. Sometimes it's even difficult to distinguish anatomically at times, parietal versus frontal on a lot of the imaging. So, you'll often see reports that'll say frontoparietal temporal. So great question, but a lot of gray right now. However, that gray is going to become clearer as we move from SPECT and we move from CT and moving over to PET and moving over to MRI and using more functional MRI and going from a 1.5 Tesla magnet, which is the strength of the magnet, to 3.0. And recently in Paris, we're at now 11.7 Tesla that is actually being used. The resolution and the power of being able to get information on exactly where and what's going on is just exponential. So I'll be talking a little bit more.
I have a loud voice. I've been told all my life.
Okay.
In association with the female trend, again, it's a small number. I noticed that the age of onset is also seems a bit higher, about mid-20s. that this is partly an acquired defect, not necessarily an early neurodegenerative defect, like what I'll call as a, these are classic schizophrenia. As
That's really smart, and thank you. It's not something we went into, but that's a great hypothesis, and one that I didn't really necessarily consider in a lot of detail as the other ones, but that definitely could be a modulating factor for earlier presentations of psychosis in people who haven't like other underlying risk factors, especially women. Right. Usually you would expect women to have first episodes of psychosis a little bit later than males. So maybe the preponderance in females earlier has to do with what you're talking about, especially because a risk factor not only for severe mental illness, but also for the seizure picture is loss of consciousness and multiple brain injuries early on. So that makes a lot of sense, and I think something we should consider.
I like Dr. Forney, there's one case in there where it was clear to me that she was playing rugby, among other things, and attacking anybody who attacks their best friend and their parents. I mean, I think that's brain damage, but there's a couple, but when we were young, when you were really interested in rheumatology, and so there's a lot of rheumatological autoimmune disorders that are predominantly female, and since we think that one of the connections between all these things might be inflammation, that might tie in that way. And I believe migraines have a higher prevalence in women, right? And so there's a few hints at something. And so again, it's a societal change, much earlier sex, much more drug use, much more drinking in young women than ever before, and more stimulant use, right? And, women, is it 45, 55%, 55% women graduating from college graduates is 55. And so there's all kinds of things changing right around us right now that may play out in other ways, right? And so this might be a reflection of stress, psychosocial issues, and inflammation, virus, God knows, I don't know for sure, but something seems a little different. The long COVID data also shows that pattern. The long COVID data in terms of cognition, neuropsych changes, it's roughly 55, 60%, 40, 45%, with the female preponderance. So that again might turn into inflammatory, vulnerability.